So excited, I was making such good time,
Oh.
because we were getting pushed down the road. Paddle, yeah, that's really cool. Once we can have a page, I'll get in, like. So we just start breaking whatever, and spread out. Got back done. Yeah, that's it.
So, Francis, did you apply? Good for you.
And then that.
Did you have to wait long?
Well, yeah.
Well, I think my name went in about 2 years ago,
Okay.
and it wasn't good timing for me anyway, but I got a phone call a couple months ago, 3 months ago now, I guess, so. It was good.
That's Stevie here.
And about the blue
And Bruce, you have health experience?
registered nurse for 46.5 years.
That's, I would say experience. That's something.
It's the health board.
Yeah.
Yeah, the foreman.
Yeah.
All right. All right, we are at 4 o'clock. I'm gonna call the meeting to order of Lakelands Public Health for Wednesday, May 20th, 2026 at 4 p.m. in the Lindsay office. I'm going to call the meeting to order and provide the land acknowledgement, again, for members of the board. If they would like to provide land acknowledgement, for the next meeting, please, let me know or leave a note, and, we welcome your personal aspects, to the land acknowledgement. So, I would like to acknowledge that we are gathered on the traditional territory of the Mississauga and Anishinaabe, and we recognize and extend our respect to all First Nations, Inuit, and Métis peoples, and their contributions past, present, and future. This past weekend, Hiawatha First Nation hosted their 30th annual traditional powwow at the Sacred Serpent Mounds site on the shores of Rice Lake. With sunshine and warm weather, it was a beautiful weekend, and I hope it provided a meaningful opportunity for Chief Carr, Councillor Wilson, the residents of Hiawatha, and the visitors to celebrate Indigenous culture and spirit. For settlers who attended, I hope it offered an opportunity to learn, reflect, and share in that incredible experience. As we are in the month of May, we also acknowledge Red Dress Day, observed on May 5th, which honors and raises awareness of missing and murdered Indigenous women, girls, and Two-Spirit people. It serves as an important reminder of the ongoing need for truth, justice, and meaningful reconciliation. I hope many of you were able to attend the local event. I was grateful to see Lakeland staff in attendance in support on that day. Right. So item 2 is a welcome to a new board member. Francis Trudeau is the newer provincial appointee. Welcome, Francis. As you are all aware, we recently received notice from the ministry regarding the appointment of a new provincial representative to the Board of Health. I'm very pleased to introduce Francis Trudeau, who has been appointed to a 3-year term. Ms. Trudeau resides in Havelock with her husband David, and together they have 4 children, all of whom are married and live in the area. She began her nursing career graduating in 1974 from both St. Joseph's School of Nursing in Peterborough and Sir Stamford Fleming College. Recently retired after 46 years as a registered nurse in Campbellford Memorial Hospital, including 20 years in the emergency department and a brief interim management role there as well. Throughout her career, she was actively involved on numerous committees contributing to improvements in healthcare delivery. Please join me in warmly welcoming Mr. Trudeau to our board. Want to say a few words or mandatory?
No, just thank you very much for such a warm welcome that I've had. I'm really looking forward to this new learning.
Wonderful.
Yes.
Thank you. You're welcome. All right, item 3 is declaration of pecuniary interest. Are there any declarations of pecuniary interest with any items on the agenda? Seeing none, if anything comes up during the meeting, let us know and we'll deal with it at the time. The adoption of the agenda. Are there any amendments to the agenda?
So moved.
Oh, thank you. We have a mover for the agenda. Seconder. Councillor Rial. All those in favor, see some hands, please. You. All right, adoption of the regular minutes, the minutes from our previous meeting were circulated. Are there any amendments, corrections to the minutes that anybody was able to see? Okay, not seeing any. Can I motion to approve the agendas, the minutes from March 15th? Councillor Royale and Mayor Vogel. All those in favor? That's carried, thank you. All right, is there any business arising from the minutes that everybody wishes to bring forward? Okay, seeing none, we will move to item 7, medical officer of health. Please.
Thank you, Chair Black. Good evening, everyone. Thanks for being here on this sunny May day. Hope you had a great long weekend and enjoying some of the sun. Don't forget your sunscreen when you're out there outside as the weather starts to turn nicer. So a few updates that I'll just go through this evening for the Board of Health. The first is emerging infectious diseases of interest. You've probably been following the dual situations with the hantavirus Andes strain virus outbreak linked to the MV Hondias cruise ship. As well now over the past few days on the weekend, the World Health Organization declaring the Ebola Bundibugyo virus strain outbreak a public health emergency of international concern with over 130 deaths now in Uganda and the Democratic Republic of the Congo. So, taken together, I won't get into deep detail on each because you can find updates on those provincially with Dr. Karen Moore, our Chief Medical Officer of Health, having spoken certainly about the hantavirus situation with Dr. Reimer, the Chief Public Health Officer of Canada, speaking about these situations as well. I won't get into the details on this, but I think just to bring up and remind the board that with globalization and rapid international travel, with a changing climate, we know half of infectious disease threats have increased with the context of climate change. Emerging and re-emerging infectious disease threats are more common than ever before. And this highlights the need for us here in Lakeland's region to be prepared. We at this point don't have any individuals isolating with exposure to either of these. In Ontario, there are a number of individuals isolating after exposure to hantavirus, no confirmed cases at this point. And from an Ebola context, we've never had a case of Ebola in Ontario. There are no individuals isolating at this point. So these are not immediate issues that we need to be changing behaviors and responding to, but they are a constant reminder of the need to be prepared for emergencies, for emerging and re-emerging infectious disease threats here at home, because viruses, infectious disease threats, they know no borders. They don't respect international borders. And so we need to be prepared and ready for them at home. And I think it's important also to advocate for global solidarity, because if these outbreaks do get out of hand in other contexts, I have some firsthand experience having been in the DR Congo when the 2018 Ebola outbreak was underway. If there isn't support and care in other places and contexts, viruses, the infectious disease threats, they do travel and they'll arrive here on our doorstep. So just a reminder of the continued need to be prepared for the next emergency, outbreak, pandemic, potentially, whatever it might be. And a big thank you to our team that's been doing internal work. We've been communicating with healthcare providers about these topics, and we'll continue to be ready and prepared to respond in the event that we do have one of these viruses or something else into the future.
Just
I'll
a quick
go through a
question.
few other things, but I'm happy to pause.
Through the chair.
Just one,
Through the chair.
Yep.
Thank you.
no problem. I just had one question. Are there any remedial medicines that can be taken for these things in case they happen?
So there are antivirals that are available for both. And neither has a vaccine to prevent it. And there's lots of personal protective equipment and processes to stop transmission that are important. So with the Ebola virus, there is an Ebola vaccine for the Zaire strain, but not for the Bundibugyo strain of the virus. So there are conversations happening about what development of a vaccine looks like, but it's not a simple switch flip. And already the number of cases of Ebola has increased dramatically. And having worked in that part of the world, there is significant access challenges geographically, logistically. There are significant healthcare capacity challenges in East Africa. So, these are potential threats. We, obviously don't know of any individuals isolating or cases here in our region now, but continued readiness is important. So the provincial governments, been doing planning, have shared communication about what it would look like. We have hospitals that are prepared to potentially, receive patients if in the future that was the case. So not an immediate threat today here in our backyard, but some, a constant reminder of the need to be ever ready for at least one. So a few other updates I wanted to share this evening, if I may continue, Chair, for you.
See any hands up? Yeah, no.
We are continuing our work in the second phase of our strategic plan. So a reminder that the first phase of the strategic planning that we're taking our time on and doing very thoughtfully as a new merged health unit. The first phase was internal conversations with staff, defining the culture and the approach to work that we wanted to create. That finished last fall, and we've been doing good work, with the values that came out of that and the conversations and actions that came out of staff input. Phase 2 is the community work and consultation, both with the public directly and with our partners. We're doing interviews and focus groups with community partners that we work with. We have a public survey, and a reminder to the board to, if you can, share through your social media channels, or if your municipality or First Nation or other organizations are a part of can share that link. It's available on the homepage of lakelandsph.ca. And still open. We've had over 100 responses, but we're aiming for many more in the coming month. The other piece to our strategic plan in phase 2 are town halls that we're doing with community. So we've already had great participation, great conversations in Haliburton County and in Northumberland County in April. Coming up, we have this evening, here in Lindsay in City of Kawartha Lakes, we have a town hall starting at 7 p.m. In Peterborough next Tuesday, May 26th from 4 to 6 p.m. In June, we'll have both in Curve Lake and Hiawatha First Nation as well, and we're planning a broader urban Indigenous engagement session and a catch-all for other members of the public that haven't been able to attend one of the in-person sessions. So those will be coming up in June. The other update I wanted to share is just we've been doing a lot of continued work around our values, and lots of conversations with staff about those values. A reminder, our values are integrity, collaboration, advocacy, respect, and excellence. Those are words on a page until you start to have conversations about what it means, what it looks like in practice. And we've been having some great dialogue with teams. I've been joining each divisional meeting. We've had some full team conversations. We've had great conversations with the management team to start to think about, as a new organization, what does it look like to live our values? I also just want to share a few things around some of our partnerships with healthcare system partners. We've been doing new engagement work, including making the rounds of meetings. I've been meeting with all of the hospital CEOs, with the Ontario health teams, to start to define what is working with our healthcare partners look like for Lakelands coming up. We also have initiated a new healthcare provider email newsletter, which is available, and any healthcare professional can sign up. It's available online. It's called the Lakelands Loop, and it comes out on an as-needed basis for urgent or interesting public health news and updates. Linked to that as well, we're going to be starting twice a year public health rounds that are going to be continuing medical education accredited. In feedback with some of the chiefs of staff we've met, there was an interest in having these CME accredited rounds to talk about important public health topics. So we'll be covering off a little bit on obviously hantavirus, Ebola, but also environmental health issues in the next one that'll be in June. And then we'll do another one in the fall that will be more focused on vaccines for RSV, influenza, COVID, and respiratory season preparedness and response. Finally, my last updates just around some of the human resources related updates for our senior leadership team. We've started recruitment for a director of corporate services position and an associate medical officer of health position, given recent departures from the organization. Those recruitments are active, the postings are up, and we're hoping to have a full senior leadership team in place over the coming months. And lastly, I'll just note that for the Board of Health, since our last meeting, we received notification from the Ontario Labour Relations Board, the OLRB, of a PSLRTA decision. So that's something we've been waiting for quite some time. The Public Sector Labor Relations Transition Act, it's a mouthful, but it's the process to bring unions together through the public sector merger. And it's a very prescriptive process to identify which unions will represent our wonderful staff here at Lakelands, the majority of which are unionized. We came into the merger with 5 different unions representing our staff, and the OLRBs made a judgment that there will be 2 unions representing staff, a nursing-based union and a union representing other unionized staff. So the representation from those unions will be discussed in coming weeks, as well as then beginning new collective bargaining with those representatives. So that is my update for this evening. Fair bit, but there's lots going on as we kind of approach the spring and head into the summer. And I think I'll just finish by saying continued work of the merger, and a huge thanks to senior leadership team, our management team, and especially all our frontline staff that are both shouldering our routine work in public health, as well as all of the added work of bringing 2 health units together as Lakelands. Thanks.
Thank you, Dr. Piggott. Any questions for Dr. Piggott on his report? No, okay, seeing none. Yes, again, I want to thank staff for all the hard work. As you say, the merger work is on top of the day-to-day work, and catching up is often difficult to do. So the board definitely thanks staff for the additional efforts that it takes to make this merger a success moving forward. So thank you for your report. Can I get a motion to receive Dr. Piggott's report for information? We have Mr. Maloney and Dr. Makicha. All those in favor? Thank you. It's carried. All right, we're going to go to reports. We have a couple of great presentations tonight, so I'll turn to Dr. Piggott to do the introductions.
Yes, thank you. Through you, Chair. Thanks to our staff for being here this evening for 2 great presentations, 8.1, 8.2. Starting first is going to be Megan. Megan is an epidemiologist with Lakelands Public Health, and her presentation, The People Behind the Numbers, is one of the educational series that we're doing. Each division at Lakelands is going to do a presentation for the Board of Health on a special topic or an educational topic, and to share a little bit about the scope of the work that they do. So we're really looking forward to hearing about the people behind the numbers from one of those people. So over to you, Megan, and thanks for being here this evening.
Thanks so much. Hello, everyone. Thanks for having me again. As Dr. Piggott said, my name is Megan Bowman. I'm one of the epidemiologists here at Lakelands Public Health. My presentation, people that go behind the numbers, is about how local data can help guide our health unit planning and evidence-based decision-making as we translate statistics into a healthier community. I'm gonna start off by briefly going over an outline. So we'll begin with going an overview of the epidemiology team, who we are, what our aim is, and what is our mandate under the Ontario Public Health Standards. We'll then dive into our special topic area, which is just for information purposes only. And this is our putting data in perspective, the growing senior population at Lakelands Public Health. We'll look at some hows and whys of this demographic shift before we conclude by looking at the actual tools the EPI team has built to provide data to our teams, community partners, and the public. So I'm going to do a quick demo of that, and then we'll have a brief question period. So the epidemiology team, or EPI team, as we like to refer to ourselves, our aim is to not just be data collectors, but instead data translators, by turning raw data into actionable insights and providing our knowledge to teams for interpretation. By taking the data we receive and turning it into digestible information to help us understand where we are headed, we act as a bridge between the available data and our program teams, helping program teams integrate local evidence into their strategies whenever possible. We do this by monitoring disease trends, health behaviors, and population status, developing data products, custom indicators, as well as supporting evidence-based program planning and decision-making. We also manage requests from both inside and outside of the organization. Our goal is to make local evidence available and accessible. Under the Ontario Public Health Standards, we are legally required to perform population health assessment and surveillance, and at Lakelands Public Health, we are the ones fulfilling that mandate. I just want to take 1 minute to recognize the people who make this happen. Andrew, Vidya, and myself are the EPI team here at Lakelands. As a group, we aim to be a steady resource for the health unit, aiming to be the data scaffolding, if you will, to help program teams build their solid foundation on local evidence. I also do just want to take a quick second to acknowledge Carolyn. She was one of our EPIs who recently moved to a new role, and a significant portion of the work still in use today at Lakelands carries her fingerprints, and we're grateful for the foundation she helped build. So when we talk about data, we tend to focus on the technical side of things, but the goal really is to understand the community that we serve. To show you what this looks like in practice, let's look at a significant demographic shift occurring in our population. So we're putting data in perspective by looking at Lakeland's growing senior population. It is projected that nearly 1 in 3 residents by 2051 will be classified as senior, and that is age 65 and over. It is a striking reality that our health unit holds the biggest projected proportion of seniors throughout all Ontario's health units through 2051. And while we can see that the proportion of seniors does vary by county, with about 26% projected for 2051 in Peterborough, to almost 40% in Haliburton, the real story here is the sheer volume of senior residents being added to our system at nearly 36,000, reaching almost 150,000 senior residents in the next 25 years. And if we look at our population pyramid over there, we can see that it's not a transient shift, but actually going to be our new permanent landscape as our population continues to age. So health complexity and system strain. As we all know, aging isn't just a number, but it's actually a shift in medical complexity as well. By 2040, it is estimated that 1 in 4 residents, that's 80,000 residents, will be living with a major chronic illness. This isn't just getting older, like I said before. This is managing diabetes, dementia, hypertension, and other chronic conditions, sometimes simultaneously. With increased complexity, it is also normal to see increased health system burden. We can look at this by looking at hospitalization costs and needs. For example, with our current costing data, a single hospitalization for an individual aged 60 to 79 is approximately $18,000. This increases to over $23,000 for a single average hospitalization stay for those aged 85 or 80 and older. We can also use our data to see where there are potential gaps we can fill. By looking at our 2023 mortality data, we can see that the Lakelands rate for avoidable mortalities among those aged 65 to 75 was significantly higher, 74, sorry, was significantly higher in Lakelands than the provincial average or provincial rate. We can see this as a potential gap that we can help fill. Additionally, seniors face various other higher risk factors, including environmental exposures like extreme weather, respiratory diseases, including COVID and influenza, as well as injuries such as falls. And these vulnerabilities are frequently intensified by health inequities, including rural health inequities, which we do face in our region. So how do we turn data into action? This is really about being proactive versus reactive. By looking at these projections, we can work with program teams to figure out where we need to put resources today so we aren't overwhelmed when the peak occurs. Our ultimate goal is to compress morbidity, providing those extra years to residents or life spent happy, healthy, and at home and not in an acute care bed. By identifying which populations and demographics are falling through our cracks, we're able to go from broad-based programming to targeted interventions through collaboration with program teams. Oh, right, sorry. So how has EPI started to work towards this? By developing interactive dashboards, including topics of chronic disease, injury, and demographics, among many others, the EPI team over the past few years has provided data to our public, our community partners, and our staff. These aren't static PDFs, as I said, but interactive tools that users can filter by age, for instance, our 65 plus cohort, by sex, or by specific geography to see what's happening in their own backyard. This allows our community partners, internal staff, and public to pull information inside. Now I'm going to steal Michelle's computer for a minute. Yes. Alright, so on the Lakelands website, we have our public health data webpage. This currently houses all of our current dashboards that have been harmonized or in the process of harmonization. So this includes our census profile, which is our demographic dashboard, chronic disease, food insecurity, infectious disease, injury, mental health, mortality, respiratory, and our substance harm dashboard, which is currently in the process of being harmonized. When you click a dashboard, it will take you to a landing page. This landing page has a little blurb about the dashboard, some key stats that EPI has pulled out, as well as a how to use the dashboard section. I'm just going to briefly go in and do a little demo. So for, while our dashboards all house different data and therefore are structured slightly differently, they do follow the same general format of our different buttons above to access different pages, as well as filters to try and drill down as the data allows. For our overall injury burden page, this page allows us to see how many emergency department visits and or hospitalizations are caused result of injury. We can also look at intent of injury. But let's do a little case study, shall we? So if we wanted to do a program based on injuries, but we weren't sure where to start, we can look at our leading causes of injury page, which shows the leading causes of injury over the past number of years. We can see counts on the top graph and rates on the second graph for injuries resulting in emergency department visits. And when we look at this, we can see that falls are our #1 cause of injury resulting in emergency department visits. We also can select hospitalizations to see similar thing for all of Lakelands, males and females, all age groups. What is our leading cause? And we see once again, it is falls. But say I know what area I want to focus in on, and I just want the data. Our injury burden page allows us to select a different topic, say sports and recreation related illness or injury, sorry. And we are able to drill down into our topic area as fine as we want in terms of age group and sex to get the information that we need. We can also look at our rates page and compare to our national or provincial average of Ontario excluding Lakelands Public Health. But say I have my topic, but I don't know where to focus. We can look at our age and sex page and see a comparison with different age specific rates to see where our cohort that needs to be focused on is. So for this sports and recreation related injuries, we can see that for most of our counties and for Lakelands as a whole, the 0 to 14 age range is the age range that we may want to focus on, or we may want to focus on, 24 and under, because those are our top 2 rates. We can also look at sex and see that males in general have a higher age standardized rate for emergency department visits related to sports and recreation related injuries. But to take us full circle, we saw that falls was our leading cause. So let's go and say, hey, we want to do something on falls. We can see that through our graphs here that our 80+ individuals are by far have the highest rates of age specific rates for emergency department visits for falls. We can also look at hospitalizations, and we can see once again that our 65+ or 65 to 84 and 85+, our senior individuals are experiencing the highest rates for falls, hospitalization due to falls. We can also see by sex and see that females are experiencing the higher rates of hospitalization for falls. So we are able to then create a targeted intervention to that group. Each of our dashboard pages also have a data note page. This includes information, context that may be useful to individuals using our dashboards. And then the last thing I'll say is you are able to access all of our dashboards from the dashboard you're on by this wonderful little carousel the comms team made for us. So if you have a burning question from reading this dashboard and you need to have it answered, you can very quickly access all of our other dashboards via this carousel below. So I believe that data is only as good as the decision it inspires, and the EPI team is here to help make those decisions the best they can be for the community in this region. And I will now answer any questions any of you may have about the EPI team or this project or anything else I can help with.
Thank you, Megan. What a great presentation. A lot of great information there, a lot of information being collected. Questions from members? I see the mates. Can't see folks yet on the screen, so we'll check in.
There are no hands
Go
up.
stop share, I guess. Yeah, no hands up there.
Yeah.
I've got a couple of questions then. Oh, sorry, Deputy Mayor Richardson, and then Mayor Vogel. Oh, sorry, did you have your hand up?
Yep, thank you.
Yeah, go first
Thank
and
you
then
for
Mayor
you.
Vogel, yeah.
Thank you for the great presentation and showing us the dashboard, how it actually can be utilized. One quick question, how can the surveillance data used to proactively identify seniors that are at risk, for example, the following?
Yeah, so for instance, with the injury, we're able to, so I'm gonna start actually. We have various different data sets. We have various different pieces of information. So the one that I just showed you looks at specifically our emergency and hospitalization data, and that can show us kind of which age population we need to focus in on. But obviously there are so many other demographics that go into an individual. So we do have survey data, which is currently not available on any of our dashboards. The dashboards are not the final suite, we would like to do more. And those are currently internal. So if we know that this is what we want to focus on, we can then work with our program teams, and it might be a combination of, their expertise as well as the literature review, some of that type of things, as well as our survey data, which has other demographics to really drill down and see what demographic, what is our priority population within that larger population. With falls, we do see that as tends to be as you get older, the falls tend to happen, which is why I use that as my example, because that could be a more broad programming piece. But if we're looking at specific priority populations, we do have other data sets that we can kind of use with our program teams to really drill down. Thank you.
Thank you.
It's not pickleball, I'm just kind of.
I was gonna ask that. Christine. Mayor Vogel, and then Warden Clark after Mayor Vogel.
Megan, thank you very much for your presentation, lots of information there, and if I forget a little bit, don't worry. My question is, Are you able to compare the results that you're getting for our board? And compare that to other jurisdictions in Ontario, and so we can figure out that we have the best practices, so that we can develop some stuff with them?
So depends on our data set. That's not a very satisfying answer, but that is the truth. So with the dashboards, any of the dashboards that are with, our standard administrative data, like the one I showed, we do have our Ontario versus or excluding Lakelands comparison, and that's because we can't actually access the data for all of Ontario, that we can have that. So that we added to allow for comparison to see kind of where we are compared to the national average. Other data sets, we may only have information for our Lakelands area. That's why it's really important for us to work with program teams, because they have the context for the specific area that we're talking about. And we do work with other health units, so there's a professional organization for epidemiologists that all of our team are members of. So we are able to kind of share that information, ask, hey, what are you guys doing that's working, and that kind of thing on that professional organization, and it is quite active. So there is lots of communication going between the different health units. But it really does need to be a collaborative piece, making those interventions and those decisions in terms of like actual programming.
Thank you for the answer.
Warden Clark?
Yes, and through you. Thanks, Megan. Great presentation. Just a question to you. Certainly, past behavior often predicts future behavior. Do we have a plan in place for patients on their first admission from a fall to focus on that with a program that extends outside the hospital into the homes to make those patients safer and possibly avoid a further fall?
So I'm the data person, yeah.
Phone a friend. Through you, Chair. No, thank you for the question, Warden Clark. And big thanks, Megan, for the presentation and the data. I think linked to tonight's presentation on how the data can help to inform, it links to one of the updates that I provided in the MOH update, just on our engagement with health system partners, because I think the more that we can use data that we have access to help to inform some of their pieces at a hospital level, at a health system level, we're working very downstream. It's, the emergency, the health issue has happened, and it's hard to get into the space of prevention from a healthcare standpoint. But that's, I think, where public health can help. And, when I think about a topic like falls prevention, a public health perspective on that might be, what are the, building code and home design related considerations that can help to make sure that houses are safer? You may not know this, over the last few decades, the building code around stairs, for example, has dramatically changed, so that stairs, the rise and run of stairs, are much different than they were if you go into an old house from 150 years ago. Your short and narrow stairs result in a much higher risk of falls. And the Canadian Public Health Association has actually done some work talking about public health's role in falls prevention over, decades, generations. So I think that there, obviously physical activity, healthy bones, and food security, which we'll have a presentation on later, impacts the health impacts of falls potentially later. So I wouldn't say that we've done a ton of this work specifically already, Warden Clark, and I'd turn to the Ontario health teams and hospitals around some of their falls prevention healthcare services more than what we do. But I think there are ways that this data, back to Megan's presentation, can help to inform conversations, especially given the aging population and the fact that Lakelands has the oldest population in Ontario, as Megan shared.
Just a follow-up, if I may, through the chair.
Yep. But
Thank you, Chair. And to the point, Megan, these stats are coming in but not identified. just as a fall, it would be very interesting to know if this was a second admission, a third admission. I'd like to know the frequency, and then looking back at if we do implement a program, is then the stats showing that we have success from it? So just some ideas. Thank you.
Thank you, Warden Clark, for information. Councilor Rail?
Thank you, Mr. Chair. My question is around, I know we got limited amounts of data, and you can't be collecting data to the point where it's crazy. But I tell you one thing, and one group that's gonna use this, and we have is our communal paramedic system. Okay, we do a lot of wellness checks, and as the province, it seems they're gonna be going a bit more in that direction now to allow more of that to happen. It would be nice for us to be able to look at where the opportunities for bad news, as in falls, anything else that matter, would happen. Older people, they're more recluse, not because they want to be, but because they have to be. And so if we could know so that we can start doing those wellness checks based on the opportunity for failure to be what it is, but also to what to look for when we go there, not just the wellness of the individual, but the surroundings about it. So examples of stuff that might happen, are there more falls in the winter than there are in the summer? Is there more in the house than in the street? That kind of stuff. And I realize that not all of that data is available, and it may be available somewhere else. I was wondering if there was anything there that might be able to help us pursue that, because I think the communal paramedics have a great job to do. They can really prevent a lot of this stuff before it starts.
So just off of what you said, we should absolutely look winter versus summer. We do have like the dates on our emergency current data, so we could do something like that, just based off of what you said just then. I think really what's going to be key with going forward into our new reality of the aging population is a lot of partnerships, because I can have all the data that I can have, but if I'm not talking to you, then you still aren't getting it, right? And so that's what we're really trying to do, and that was kind of our aim of the dashboards and why we want to continue to build the relationships, even just in our FE team as ourselves and within the public health unit as a whole, because we need the data to get out there to be useful, not just for us, but also for like our EMS partners, that sort of thing. So there's definitely things we can explore even within our administrative data, which is more restrictive in terms of what they actually collect, such as like seasonality for sure. But I think there's this second piece of the communication.
So, thank you, sir. Is it possible, or does it currently exist, to have special training that would be available for like our paramedic services and people like that, where they could tune in at some given point in time along with any other group that's interested, and find out more of how that particular tool could supply them with information on how to use the tool effectively? Is that possible?
It does not currently exist, at least not by us on our tools. I think it would be possible to take it back to the team to discuss it, but I don't see why it wouldn't be possible. In terms of like having, training sessions or whatever for the public or health partners. I will say I have had program teams reach out asking on behalf of community partners, hey, can you do a demo of this dashboard? And we have done that. So it kind of exists, but not to the scale I think you're talking about, but yeah.
Thank you.
Through you, Mr. Chair, I know that there are currently emergency departments who part of their triage interview is falls. So it covers all of that, and then there's a follow-up before they go home. And I know they do track subsequent falls admissions. So there's data there for.
Yeah, so we do have access to our administrative databases. They do have when I say restrictive, I don't necessarily mean restrictive in the sense they do have a ton of variables, but they're not necessarily capturing fall at home versus fall at like those sorts of things. But no, I definitely agree, like we could look into repeat admissions, that's not been looked at recently or before, but that is something.
Yeah, they have a fall prevention program within the hospital, at least the one I worked at, so I imagine other places, yeah.
Something to look into.
Thank you. Megan, I got a couple of quick ones, and the challenge with all this always is collecting and connecting the data to programs, which we're not typically responsible for, but to bring them outside and make those connections. Greatly, you're going around showing the data and how they can get it and they can produce programs. As you said, the cost of one admission or broken hip or something like that would pay for the program for the whole year, basically. But so that's just a comment. One of the things you talked about was the percentage of seniors at 30% by 2051. One of the other challenges of this whole area is we have a lot of seniors moving to the recreational property. And often those properties are old cottages, Dr. Biggin mentioned old stairs and stuff like that. So, when you pull your numbers, do you account for that population growth that is not just people aging, but organic growth from people coming from other areas, because we are the cottage country?
Yeah, so when we're looking at our projections, these are the projections released by StatsCan.
Okay.
So they do take into account other things, and we get updated population projections and estimates over time. So they will get, as we approach 2051, we'll get more accurate estimations as we go. But you're right, it's not just our population physically aging, it's also we are retirement region, so.
One of the things about.
Yeah, everyone, complete your census, I did mine, complete your census.
And Deputy Mayor Richardson wanted to know whether you can separate pickleball injuries out from the other balls.
So we do have sports and recreation related injuries, and I will say they are separated out. So if it was a sports related injury, which I do think pickleball is classified as, therefore it would be separate from the rest of the balls.
There you go. Thank you. Again, thanks for your presentation. Fantastic. Appreciate it. Thank you. All right, presentation number 2. Oh, we need a motion, sorry. We need a motion. Oh, sorry.
Clark?
We're talking the legacy band up there, or is that?
I will make the motion to receive the report, but when I worked Emerge, one of the highest injuries was knife injuries from cutting bagels over the weekend.
Exactly.
Category. So, Warren Clark has moved, receiving the presentation of information, seconded for that, Deputy Mayor Richardson. All those in favor? See your hands, thank you, that's carried. That's Bonnie and, okay. All right, so our second presentation, I'll turn over to Dr. Britt as well to introduce the item.
Yeah, we are joined by Lauren and Sarah, who are going to present our food insecurity and food affordability report. So for the board's info, as Lauren and Sarah come on up, the food insecurity reporting and food affordability assessment is part of the Ontario Public Health Standards. It's a required report for health units to do, and I think a great example of harmonization work, these teams, we have one person from Legacy Peterborough Public Health and one person from Legacy HKPR up here, but they're actually both Lakelands now, and one of them sporting a t-shirt nicely, so, and the other one a bit of colors. There you go. So this is, I think this is also just a great example of how staff are working together to create a new Lakelands way of doing things and bringing it together. So big thanks to you both for being here this evening and presenting really important data on food insecurity. And I'm sure they'll do a plug on income, but really as we think about our communities, not only in Lakelands, but across the province and country, affordability is a huge challenge. Cost of living and affordability is a huge challenge and has huge impacts on health. So very important topic, and thanks for being here and presenting.
Thank you so much for having both of us.
As Dr. Pickett said, I'm Sarah Sang, Health Equity Coordinator and Registered Dietitian. I work out of the Port Hope office on the Indigenous Health team. And this is Laura Kennedy, my partner in crime. She works out of the Peterborough office on the nutrition team. And today we are presenting on food insecurity and food affordability in the Lakelands Public Health. Just a quick outline of what we want to cover in the time that we have together. We want to start off by defining what household food security is and what the impact it has on health. Then we want to talk about monitoring food affordability and what those results mean using a family income scenario, a family on Ontario Works. Then we want to talk about the solutions to household food insecurity and what we are doing as Lakelands Public Health to address household food insecurity. So household food insecurity means not having enough money to buy food. And what that can look like can range from having concerns that food is running out without money to buy more food. It can also look like not being able to buy the amount or the variety of food that you need or want for a balanced diet. It can also mean skipping meals, missing meals. And at the extreme, severe household food insecurity can look like this going hungry because you haven't eaten for days. Whether the experience is marginal or severe, it is a serious public health issue that reflects real challenges families face in meeting basic needs. In the Lakelands area, from 2022 to 2024, about 22% of households were food insecure. That's close to 1 in 4 households. Food affordability shapes eating patterns. Higher food prices add to the challenge of eating nutritious foods. When families don't earn enough money, food is often the first thing to be cut from their budget so that they can use that money to pay for other basic needs like rent or utilities or childcare. Spending less on food can also mean less nutritious meals are eaten, if any at all. And we know that poor nutrition increases the risk for chronic conditions and mental health illnesses. Research shows that children living in food insecure households are more likely to develop depression, more likely to develop asthma later in life, and have issues with hyperactivity and inattention. Adults in food insecure households are more likely to report poor mental health, have higher stress and anxiety, and have higher risk for chronic diseases like diabetes or heart disease. Household food insecure also makes it that much more difficult to manage chronic conditions, either through nutrition or through medication. And so in short, as the severity of household food insecurity increases, so too do the costs to our healthcare system. Since 1998, and currently through the Population Health Assessment and Surveillance Protocol, Ontario Public Health units are required to monitor the cost of a nutritious diet using a tool called the Nutritious Food Basket, or what we like to call the NFB survey. The Nutritious Food Basket survey measures how much it would cost to eat according to Canada's Food Guide. And we do that by going to different stores in our local health unit region and price out a list of foods. And we collate those results and have an average of the cost of food. And the result of the Nutritious Food Basket, when put together alongside income and non-negotiable expenses like rent, can paint a picture showing how important income makes to household foods. Now today, we are talking about the results based on last year's food affordability results. And we recognize that we are delayed in releasing the 2025 food affordability data. But we wanted to take the time to work through some considerations. One of the considerations is we wanted to best represent the Lakelands region using combined nutritious food basket data that was collected from Legacy, Halliburton, Kawartha, Pine Ridge District Health Unit, and Legacy Peterborough Public Health. The extra time also allowed us to set a foundation for a consistent sampling approach for the Lakelands region moving forward. We also considered how the information could be localized to our 5 communities. So you will see on the infographics in front of you and also on our dashboard, there are some regional differences to the housing costs in the family income statements. And so now I'll pass the time forward to speak more about what those mean.
Thank you, Sarah. So as mentioned, when we just heard about dashboards, we do have a new dashboard that's been updated. With 11 different family breakdowns, different income sources, different family structures for the 5 different areas that Sarah mentioned within Lakelands. So this is just one on the screen here. This is a family from Northumberland on Ontario Works. This scenario is actually relevant to the Alpha resolution that across your agenda package. Speaking about Ontario Works policies that can help families who are on Ontario Works. And so we consistently see that this is an income source where families do not have enough money to meet their basic needs. So this family, and this is the case regardless of which area within Lakelands, there is a deficit after paying for rent of, and that's not counting for other expenses like transportation and heat and clothing. And we know that there are huge consequences for health and for child development, for chronic disease risk and overall health. And so, yeah, 96% of income in this situation would be required for rent, and 41% would be required for food. So when we look at, what can we do about this situation? How can we solve this? So often when we think about household food insecurity, some solutions that might come to mind would be, well, what about food banks or meal programs or other food-based responses? And emergency food interventions, there may be benefits to all of those things. There are benefits to some of them for sure. But we actually have systematic reviews now that show that those food-based interventions don't actually change household food insecurity status. But the research does show that income-based solutions, so policies that impact the incomes of the lowest income families, can move the needle on household food insecurity. So for this specific family that we just looked at, what are some examples of that? So one example is child benefits that are adequately designed to support low-income families. Another example is Ontario Works rates that match the cost of living, or something like a basic income guarantee. And the Alpha resolution speaks to some modest modifications to Ontario Works that could still help families in a small way. And so what are we doing at Lakelands to address this? Sarah and I are very busy. I feel like there's a lot of things happening, but one of the things is that we're continuing to monitor food affordability and report on household food insecurity. So this data is used at the local level. It's used by local networks. I work really closely with the Peterborough Food Action Network, for example. It supports decision makers. We use it to raise awareness in the community about the health impacts of food insecurity, and we do a lot of collaboration. This is not an issue specific to Lakeland's public health. This is a provincial issue. This is a national issue. And so we therefore collaborate. We're very involved with the Ontario Dietitians in Public Health, and Sarah and I are both have different leadership roles in some of that work. We're collaborating with Health Units on a provincial report right now, with Public Health Ontario to look at how food insecurity is affecting specifically families with children and how that connects to adverse childhood experiences. So that work is currently underway and will be used for informing policies. Another really important piece around this work is that we recognize that the current definition of household food insecurity is rooted in colonial frameworks, and it doesn't reflect Indigenous understandings necessarily or their experiences of food systems, food access, and well-being. So it's really important for us as staff to continue to have ongoing conversations with First Nations and urban Indigenous communities, looking at how can we work towards food sovereignty, Indigenous food sovereignty. And that's a topic that is so important that it merits its own conversation. But we did want to acknowledge it because it is connected to this. So yeah, thank you very much for your attention, and we'd like to welcome any questions you may have.
Thank you, Lauren, and Sarah, for the great presentation. Open the floor to questions. Deputy Mayor Richardson
Thanks.
first.
Through you, Chair, appreciate it. Great presentation, and it's really humbling when you think about what's happening out there. When you look at our food banks right now, I work very closely with a lot of our community food banks in City Fort Lakes and the pressures that they're feeling and the amount of families that they're now servicing, and also looking at the food inflation. I mean, we can see it, what's happening. It's in the news every day. Based on what we are doing, and I know that we have some recommendations and you guys are working in partnerships when it comes to policy and stuff like that. Is there anything else that we can do locally to have more of an impact to help you get the message out, maybe in a broader aspect as well? Because we're at a point right now where we're getting into a crisis situation, and I know, speaking with a lot of my residents, like I said, I work with a lot of the food banks locally. I'm seeing the impact from where we were just in 2018, come through that pandemic, we had a surge, and now we're going through another surge. I'm just wondering, is there anything else that we can be doing?
Yeah, I think, for those who are experiencing household food insecurity, there's not that space for them to like advocate for, you know, these upstream solutions. So I think as privileged with that space to continue to bring the awareness that household food insecurity requires policy solutions. And so when the opportunity arises to continue to voice that, I think that is very important, and a role that we all have that we can play.
Yeah. And off of that as well, I think you raised such an important point. Just there's so much need right now, and these policy changes take time. And so there's this tension that we have between how do we help people right now while recognizing that, you know, like Food Banks Association itself, the Ontario Food Bank Association acknowledges that food banks won't ever fix food insecurity. But people have immediate needs right now. So I think it's also a question of how do we make sure that we don't position these things as they're gonna fix the problem? Because that's actually exacerbating the problem when we think, oh, we can just donate to a food bank and we don't have to do anything else. People are staying stuck in these situations. So how do we balance, yes, we need to make sure people are okay right now, but we also need to get the message out and move up the continuum more upstream to look at how do we make sure that people have enough income to prevent this. So practical, like from a practical perspective, I think. I just think about the Peterborough Food Action Network that I work really closely with. We have people who work at food banks. We have people facing food insecurity. We have people who work in various different advocacy roles or different fields of work. And I think that collaboration, coming together, learning from each other, working together, we can identify opportunities to bring all of those pieces together.
Okay, thank you. I've got Ward Clark and then Councillor Royale next.
Yes, thank you. And through the chair, looking at the different scenarios, county by county, what comes out glaring as the percentage of income required for rent. Not only should there be a basic income, but rent geared to income certainly should be advocated for as well in order to keep roofs over. If you don't have a roof over your head, how do you, support a family and the mental health, etc. So I think there should be more rent geared to income in order to help stabilize.
Thank you, Ward Clark. I think we made that point. Thank you. Councillor Royale.
Yeah, I guess, so you said, I guess I'm showing my age, but once upon a time, you used to go to a bakery and get day old. You used to be able to go to somewhere and you can get something that wasn't out of date, but was moving towards the end of the day. Now you can't do that much anymore. Now it just disappears. It's not allowed to be sold. Tim Hortons used to do it. Wonder Bread used to do it. They all used to do it at one point in their lives. Now they're not allowed to do it. Specifically cannot be done. It's actually you see in dumpsters. So maybe in the world of trying to get more healthy in one way, we're cutting off our nose in the other way. I don't know how to solve the problem, and I don't have an answer. I'm bringing up a situation that through the higher control of some aspects of what we do, we're actually creating problems in others. So I'm not sure about how regulatory we could be, and if there's anything we could do to do that. In other words, if something is a day older, is it still edible or is it rotten? And those are the kind of things I don't even know if the health is involved in anything like that. But I know in my day, when you used to go to Wonder Bread in the morning, you could see people lining up. And they would get free bread or they get it so discounted it wouldn't even be funny. Today that option is gone. And so, and there's no more money. Unless somebody can invent or develop a money tree, which then of course would become expensive to buy. But it just doesn't make any way to solve the problem. That is not a financial issue.
Well, as we have started and defined household food insecurity is about not having enough to buy food. And as Lauren has said that, there is this balance of, because currently, there are people who are struggling. But at the same time, we know that solutions in solving those problems lie higher up with policy change, and that takes time. So they're like balancing, needing to address the needs, immediate needs currently, and continuing to ask and demand for those changes to be made at the decision-making level, so that, that there are supports still that continues to be built.
And to add to that as well, I think another implication of what you're speaking about is actually related to food waste and climate change and all of those pieces. And so and that goes into some of the food systems work that the health unit does as well. And how it's so important that we work towards healthy, sustainable food systems. And, so that's another thing that I think about as well, it's just the importance of thinking about sustainability within our food systems, for sure.
So all these different parts to the issue is so big that like, yes, income is the solution, but there are also like different pieces to this puzzle that all kind of needs to be worked on a little bit at a time so that, ultimately we have the goal where we do have.
Yeah, I just have one item, but really it has to do with rural food banks. Talking to somebody who runs one a couple of weeks ago, their numbers are threefold in the last year alone, and it's a reflection of people trying to find reduced rents, leaving the city where the rents are higher and coming to more rural places where rents are maybe a little bit less. So I think there's a disproportionate impact on rural residents because of that. So I don't know if the data is separated. I know in our township we have 3 food banks, which is, you think we need 1, we've got 3. So just a comment. Thanks for your presentation. Appreciate it. I think it's great information. Can I get a motion to receive the presentation for information? Dr. Stelzer and Dr. Keach, all those in favor? That's carried. Thank you. Thank you.
And if you're interested, there are infographics on the side of the paper as well.
Fantastic. All right. All right, so we're gonna move to item 9, which is consent items. There's 9.1, 9.2, ABC and V. And 9.3, 9.1 is minutes from the ad hoc meeting of February 20. 9.2 is the quarterly reports. And 9.3 is the Alpha AGM, 4 resolutions that are going to be presented there to vote on. I read that there's a shortage of ability to go to Alpha. You didn't get in, right?
As far as we know,
Just the 2, eh? Yeah, which is unfortunate, yeah. And so, are there anything want to be pulled from the consent items for discussion? I don't see any hands. All right, so let's get a motion to motion to pass all the consent items as presented. I have a motion table here, and we got Councillor Rial and Ward Clark. All those in favor? Thank you. All right. Item 10 is new business. Is there any new business anybody wants to bring forward? Not seeing any new business. And there are no motions for in-camera session today. No in-camera session. All right. Probably one of our quickest meetings in a long time. So our next meeting is Wednesday, June 17th, 4 to 6:30 at First Lake First Nation is what I'm gonna post. And thanks to Councillor Wilson. No, it's not. Oh, Councillor not, Third Lake, sorry. He's not on. Oh, no. Oh, is he? Oh, he's
Yeah.
just. Okay, sorry, no.
No worries.
I didn't see your thing up there. Okay, so, yeah, and as I said earlier in the meeting, if somebody wants to come with line acknowledgement, I'd be prepared to offer that up to anybody that wants to do it for that particular meeting. All right, so our meeting is completed. I need a motion to adjourn the meeting at 5:07. And we've got Mr. Maloney and Councillor Lachita. All those in favor? It's carried, thank you.
What-